Okay, so very good evening, dear students. I am Dr. Dharmendra Singh, your psychiatry faculty. Yesterday we had sessions until 18th MCQ we have discussed yesterday. The last MCQ we discussed mental retardation, intellectual disability. So today we are going to start from the 19th MCQ. I hope you enjoyed the session yesterday, and today will the rest MCQ we are going to discuss. In between, if you have any query, please let me know. So shall we start? Are you ready? Okay then. A woman complains of difficulty in sleeping at night. She says that she gets thought that her parents may be die in an accident. She similarly has may other worries. What's your diagnosis? So the options are GAD, adjustment disorder, obsessive compulsive disorder, panic disorder. So it is nothing to do with the obsessive compulsive disorder, and it is nothing to do with the adjustment disorder if you know the concept about this disorder. If suppose you have even a confusion in a generalized anxiety disorder and panic disorder. So panic disorder, yesterday we have discussed that in panic disorder we have the somatic symptoms and the psychic symptom apprehensions, but it's not like sleeping at night difficulty we can have in panic disorder also, but patient thought that our parents may die in an accident. She similarly has may other worries, so it's a more likely generalized anxiety disorder. So when we talk about the generalized anxiety disorder, in generalized anxiety disorder, generalized anxiety disorder, we divide the criteria of GAD in two parts. One is major criteria and one is minor criteria. Okay, the major criteria: the patient have excessive worry, excessive worries. Person has excessive worry. Person knows that she or he is having excessive worry. Why? Because anxiety disorder is a neurotic disorder. Insight is present, but patient is not able to control that worry. Okay, so there is excessive worry, but patient is not able to control that worry. In minor criteria, we have the patient has irritability, 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 sleep disturbance, muscle tension, easy fatigability, easy fatigability. Okay, decrease attention and concentration. Okay, so irritability, sleep disturbance, muscle tension, easy fatigability, decrease attention and concentration. Okay, out of these major and minor criteria, usually we say the two major and three minor criteria at least for 6 months, then we can make a diagnosis of GAD, generalized anxiety disorder. So in generalized anxiety disorder, the examiner will use the word excessive worry, having a worry about the future, that this is not going to happen, or and apart from that, in the free floating anxiety, sometime examiner using the word free floating anxiety means the anxiety is in every domain, free floating anxiety. Okay, yeah. So in this MCQ, the answer will be MCQ. I will see here, so you will not have any issue. Yeah, so So the next MCQ is, so the 19th MCQ answer is generalized anxiety disorder. The next MCQ 20th. So number 19 answer is A. Question number 20. MCQ number 20. The patient has an episode consisting of mania, hypomania, and depression in last 1 year, and these episodes are 6. There was complete recovery in between the episodes. What's likely diagnosis? So when we have rapid cycling bipolar disorder. In rapid cycling bipolar disorder, we have at least 4 episodes in last 1 year. If the patient has at least 4 different episodes in last 1 year, 4 different episodes, sometime mania, sometime depression, sometime hypomania, we call it a rapid cycling bipolar disorder. So yesterday some students were asking that bipolar disorder, what is bipolar disorder? We have at least 1 episode of depression and at least 1 episode of mania or hypomania. But in lifetime, if the patient having a 1 episode of depression and 1 episode of mania or hypomania, we call it a bipolar disorder. And we have a bipolar disorder type 1 and bipolar disorder type 2. Just please remember, type 1 bipolar disorder means depression plus mania, and bipolar disorder type 2 is depression plus hypomania. So depression is common in type 1 and type 2. In type 1 we have mania, in type 2 we have hypomania. Type 1 and type 2 bipolar disorder. Yesterday treatment I mentioned that we have a lithium, we have valproate, we have a lamotrigine, oxcarbazepine, carbamazepine. Okay, I told you yesterday the indication of lithium, and today I'll just mention that if they ask the indications of sodium valproate, that in which bipolar disorder we start the sodium valproate. Number 1, rapid cycling bipolar disorder, which we discussed now only, rapid cycling bipolar disorder. And apart from that, we have the comorbidity. We have, yesterday I mentioned that we have substance use disorder and personality disorder are the disorder which are comorbid with the bipolar disorder. So when the comorbid psychiatric disorders are there along with bipolar, then we have the drug of choice is what? Sodium valproate. Okay, and we have dysphoric mania. We have mania plus irritability. So irritability is not a very common symptom of mania, but in some patient along with manic symptoms, if we have a irritability as a feature, we call it a dysphoric mania. So these are the indications for sodium valproate. So the question number 20 answer will be D for Delhi. Answer will be D, rapid cycling bipolar disorder. Question number 21. A child is referred by the school as he faces difficulty in making proper sentences. Otherwise, his intelligence level appear normal. He is good in mathematics and his social behavior is appropriate to what's likely diagnosis. So, see, IQ is normal. It means it can't be mental retardation. The child is there, so it is nothing to do with the depression. Also, child is like exam phobia. During exam he or she can have a problem, but not normally that he or she will have a difficulty in making sentences. So it's a specific learning disorder. Okay, SLD. specific learning disorder. So what is specific learning disorder? Hello. Yeah. Dipanshu, fatigability means the person is having a, the feeling of weakness, fatigability, weakness. Okay. Okay. Done. Any other queries? Okay. So yeah, so we were discussing specific learning disorder. In specific learning disorder, you must have watched that the Amir Khan movie Tare Jami Pe. He, like already many years before he made this movie. So this is the specific learning disorder. We have one dyslexia. Dyslexia, is the slang, the common people language, but in our scientific term we call it a specific learning disorder. In this, the child has either difficulty in reading or writing or mathematic or mixed mixed. Okay, yeah, mix of reading, writing, calculation. The IQ of child is normal in specific learning, normal, that you have to. Either child will have a difficulty making sentence, reading some alphabets or words, instead of u he will read v's, instead of m he will read w, something like that. Okay, so this is the specific learning disorder, one of the child psychiatric disorder. Yesterday mental retardation we have discussed. This is specific learning disorder. Briefly I will tell you about the ADHD. If they ask you, ADHD, attention deficit hyperactivity disorder. Okay, before we were making the the ADHD, up to like 7 years of age, and now in a recent change in DSM-5 and ICD-11, we have up to 12 years of age we can make a diagnosis of ADHD. Okay, ADHD, we have either issue of inattention. The child have a issue of inattention. He is not attentive. He is not able to focus the things. He appears that not following the instruction. He is not able to, so the decreased attention. Apart from that, the child having a hyperactivity. The school teacher will complain that sir class में एक जगह टिक के नहीं बैठता है, child is not able to sit at one place properly, or while walking on a road also he will jump from here and there. Hyperactive child. And impulsive child is very impulsive. He or she will not able to wait for their turn. If two children are sitting, you are asking one child, the another child will try to give answer. This is the word impulsivity. So inattention, hyperactivity, impulsivity. If they ask you the treatment of choice, in some book it is written that the behavior therapy, no, the child is not able to sit at one place. बच्चा टिक के नहीं बैठ पाता, how you will do the behavior therapy? So the treatment of choice is what? Methylphenidate. Basically it's a drug, it's a medication. We have methylphenidate and we have amphetamine. Methylphenidate is a drug of choice. The child age is 6 years or above, 6 year or, and up to 6 years we are giving amphetamine or dextroamphetamine. Why methylphenidate we don't give below 6 year? Because there is a serious side effect of methylphenidate, and that is growth retardation. Okay, so we have insomnia and growth retardation. These are the serious side effect of methylphenidate. Because of growth retardation, before even starting the methylphenidate, we have to check the height and the weight of the child, and intermittently we check. And also when the winter vacation or summer vacation is there, then we don't give the methylphenidate intermittently to avoid the side effect. We call it a drug holidays. So if they ask you that drug holidays concept we apply in which drug? Methylphenidate. Otherwise it's a very good drug. Second, you have to prescribe this medication in the morning and only afternoon, not in the night, because in night if you will give, the child will have a insomnia, sleep disturbance. घर वाले बोलेंगे सर पहले तो टिकता ही नहीं था, अब तो सोता भी नहीं है, so this is a, you have to give in morning and afternoon only. This is about the ADHD. Up to 12-year wala you have to remember. Disruptive behavior disorder also I explained you yesterday. Okay, conduct disorder and oppositional defiant disorder. Only one is left, autism, that the in subsequent MCQ we will discuss. Okay, clear? Yeah. Okay, next is the next MCQ is, so question number 21. Answer is A, specific learning. 22. A 24-year-old lady presented with sudden onset chest pain palpitation lasting for about 20 minutes. She says that there was 3 similar episodes in the past. All investigations were normal. What's likely diagnosis? Okay, so again with see panic disorder, multiple times this MCQ has been asked, so I request you please read carefully panic disorder and don't confuse with any other diagnosis. In this MCQ also, the person having a chest pain palpitation lasting about 20 minutes, he says there were 3 similar episodes in the past, all investigations are normal. So answer will be what? Answer will be panic attack. Okay, so question number 22, answer is B for Bombay, already we discussed. 23, all are stages of death except. So there was a person Kubler-Ross. He actually given the stages of death. He has given the stages of death. And in stages of death we have the mnemonic dabda. Okay, dabda. Initially person is in a denial. One lady having a some issues, some abnormalities in the report. The doctor is saying, sir, unfortunately, but I am really sorry, but unfortunately you have some abnormalities in the blood test. We have to, I think probably some type of cancer you have. We have to further investigate it. Initially patient will be in a denial. No, I don't think I can have a cancer. I will not go for further investigation. Denial. Then the person will be angry with the God, that why you have chosen me, why not others. Okay, then she will bargain with the God, and then the person goes in the depression, and in last there is a acceptance that yes, it has happened and I have to live with it, I have to accept whatever it is there. So these are the stages of death: denial, anger, bargain, depression, and acceptance. Okay, dabda. So all are the stages of death except denial is there, uh, anger is there, bargaining is there, agitation won't be there. So answer will be D for daily. Okay, so there will be acceptance, not agitation. So question number 23, answer is D for daily. Question number 24, which of the following is not a formal thought disorder? Okay, formal thought disorder. So in formal thought disorder, in formal thought disorder, okay, informal thought disorder. We have, this is important MCQ, many students have difficulty in this, disorders of flow or stream of thought. Okay, flow or stream. This we have flight of idea. Flight of idea we have in what? We have in mania. In flight of idea, the patient has pressure of speech. Pressure of speech. Because of pressure of speech, patient will start from one topic, then he will shift to the another topic, then the another topic, then the another, and the association may or may not be found between these topics. So this is a flight of idea by definition. That person shifts from one topic to another topic and association may or may not be found. There is a pressure of speech and it is found in mania. Second, the second disorder of flow or stream of thought is prolixity. Prolixity is also basically we have in what? Hypomania. In hypomania there is also pressure of speech. So what is the difference between prolixity and flight of idea? Flight of idea we have in mania, prolixity we have in hypomania. Flight of idea, person will shift from one goal to another goal, one topic to another topic, and association may or may not be found. That's why flight of idea is a non-goal directed. Non-goal directed. You are asking one thing, patient may be shifting to the many other things, so it is not goal directed. Hypomania is a less severe mood disorder compared to mania. So in hypomania also pressure of speech will be there, but patient will be on a same topic. So patient will speak faster, the speed will be faster, but the patient will be on a same topic. This is prolixity. So it's a goal directed. Patient will talk about the same topic. But it is goal directed. Flight of idea is not goal directed. The third we have thought block. Thought block is sudden stoppage of thought. Sudden stoppage of thought. Person is talking to you, suddenly the patient will stop, and suddenly he will forget that, okay, doctor, I don't know what I was talking about. This is a like sudden, and then the patient will ask you. So this is thought block. So thought block, prolixity, the flight of idea, even we have clang association, they all are coming under the disorder of flow or stream of thought. And we have a form of thought. We have disorder of form of thought. Okay, in this we have derailment. Patient, like a railway track, patient got derailed. The person will start from one topic, then shift to the another topic, then the third topic, then the fourth topic. Like railway, the train got derailed from so this is the like a derailment. The patient start from original topic, then the shift to the another topic, then the another, and never comes back. He got derailed further and further and further. This is derailment usually we have in what? In schizophrenia. So derailment we have in schizophrenia. Okay, derailment we have in schizophrenia. In flight of idea also, the person goes from one topic to another topic, patient. In derailment also same, but what's the difference? The flight of idea, there is a pressure of speech. In derailment there is no pressure of speech. So flight of idea, there is a pressure of speech. Derailment, there is no pressure of speech. Flight of idea found in mania, derailment found in schizophrenia. Okay, we have Tangentiality. Tangentiality, patient start from the original topic, then he goes to the another topic, then the another topic, but he touches the original topic. Like you ask the patient, tell me about Delhi. Patient started from Delhi, then he shifted to the many other topics, but in between he tried to touch the topic Delhi. This is tangential, like patient is tangential to the original topic. Okay, tangentiality. We have another form disorder. We have verbigeration. Verbigeration, it's like a word salad. Person is just keep repeating the few nonsense words again and again. It's a very like severe, you can say it's a most severe formal thought disorder. The most severe formal thought disorder, because of severity of the schizophrenia or the psychiatric disorder, person is not able to make a sentence. He keep repeating the nonsense some words. This is the verbigeration. Okay, yeah, verbigeration. Apart from that, the verbigeration, we have neologism. Okay, we have neologism. Neologism is what? Completely new word. The completely new word, like patient making completely new word. By definition, what is neologism? Completely new word which is not existing in a, or which is not found in a existing literature and vocabulary. So this is the neologism. Patient uses the completely new word which is usually not found in a existing literature or vocabulary. Basically, neologism is a characteristic of schizophrenia. If the patient has neologism, there is a very high chance that the patient having a schizophrenia. This is so neologism. These the derailment, the tangentiality, the verbigeration. Okay, even we have a circumstantiality. Circumstantiality is what? Circumstantiality is usually also we use the word that person is circumstantial. Yeah, don't be circumstantial. So suppose I ask the patient, one person is there, I am asking, please tell me how to go to the IGI airport. He will start telling me. He will tell me the ultimately the how to reach to the IGI airport, but he will give many unnecessary tedious detail. Go here, then the right, then the left, there is a monkey shop, or so many so many unnecessary details, but ultimately person reaches to the goal. This is circumstantial. So these are the formal thought disorder. I told you little in detail because usually students have confusion in this area. So which of the following not for now? Tell me. So neologism, yes. Derailment, yes. Tangentiality, yes. Delusion is not a formal thought disorder. Delusion is a disorder of thought. Yesterday also I told you that delusion is a disorder of thought. Okay, delusion is a disorder of thought. Correct? That's a disorder of thought. Delusion come in a what? Disorder of content of thought. Please remember these MCQ, they are asking again and again. So under content we describe delusion, under perception we describe illusion and hallucination, and under possession of thought we describe obsession. So question number 24, answer is A. Question number 25. To diagnose post-traumatic stress disorder, the symptoms should persist for more than post-traumatic. So we'll discuss before, guys, we were talking about post-traumatic stress disorder, the PTSD we were counting under the anxiety disorder. Now we have a trauma and stress related disorder. Trauma and stress related. The trauma and stress related disorder. In trauma and stress related disorder, we have PTSD, we have acute stress disorder, acute stress disorder, and we have adjustment disorder. So before adjustment disorder, we were counting under mood disorder, and PTSD we were counting under anxiety disorder. Now in DSM-5 and ICD-11, we have separate diagnostic entity, and that is trauma and stress related disorder. Under this umbrella, we describing these three disorders: PTSD, acute stress disorder, and adjustment disorder. Okay, so first we'll talk about PTSD. For making a diagnosis of PTSD, we need a one first criteria is what? Catastrophic event. Catastrophic event. Okay, so one event is a stressful event, can be stressful for one person but not for other person. But catastrophic event by definition is an event which causes stress in almost everyone. Examples of catastrophic event are like tsunami, like flood, like earthquake, like sexual assault, rape, major accident. These are the catastrophic events example. Okay, so can you enjoy the tsunami? Can you enjoy the earthquake? No. So they causes the stress in almost everyone. After once the person exposes to the catastrophic event, then he or she is having a flashback of those events in the dreams and thoughts. So second criteria is flashback. The patient will have flashback of this event in what? In the thoughts and dreams. And the third, patient have hyper arousal and anxiety symptom. Patient will have hyper arousal and anxiety symptom, and the patient will have avoidance behavior. In future he will try to avoid such events. Like if you know having major accident on a particular road, you will not feel like going there anymore in future. Okay, now the duration criteria is important. This PTSD, like within 1 month, 1 to 6 months, and after 6 months. So within 1 month, we call it what? We call it a acute stress disorder. Please remember this MCQ they are asked. So within 1 month, we call it a acute stress disorder. After 1 month till 6 months, we call it a PTSD, post traumatic stress disorder. And after 6 months, we call it a PTSD with delayed on PTSD with delayed on. Okay, so within 1 month, acute stress disorder, 1 to 6 months, post traumatic stress disorder. After 6 months, we call it a PTSD with delay. So we can make a usually we make a diagnosis of PTSD within 6 months, but we can make even after 6 months. Okay, now even in ICD-11, we have one new diagnostic entity, and that is complex PTSD. Complex PTSD. So complex PTSD by definition, the patient having a repetitive, this traumatic event like slavery, like sexual or physical abuse, and because of that the patient having this emotional numbness, he feels detached from the family member or the environmental factors or the people. And this is a complex PTSD. First time this diagnostic entity we are using in ICD-11. So to diagnose the post-traumatic stress disorder, the symptoms should persist more than 1 month. So this in 28 answer will be 25 answer will be B for Bombay. Why more than 1 month? Because up to 1 month we call it a acute stress disorder. After 1 month we call it a PTSD. If they ask you the treatment, okay, the treatment of choice in PTSD is what? CBT, cognitive behavior therapy. Cognitive behavior therapy. Okay, before we were using EMDR, eye movement desensitization and reprocess. Okay, eye movement desensitization and reprocessing, EMDR we were using, but over the time it has been seen that it is not a good therapy. It is not a good therapy. Okay, EMDR. So this is the question number 25. Answer B for Bombay. Number 26. Fear of places from where escape is difficult is called, we have usually these phobias. One MCQ they are usually they can ask, so we'll discuss. So question number 26. Phobias we will discuss and then we'll come to the MCQ. We have fear of, or I will just give that name. We have claustrophobia. Claustrophobia. Fear of closed space. Fear of closed. Then we have aerophobia or acrophobia. Fear of height. Then we have algophobia, fear of pain. Okay, we have cetophobia, fear of eating. Okay, we have fear of strangers. Okay, xenophobia. Okay, we have fear of dogs, cynophobia, fear of animals, zoophobia, fear of darkness. Okay, we have nyctophobia. Okay, nyctophobia, fear of darkness, nyctophobia. Correct. So these are the various phobias we have. One, we have agoraphobia. In agoraphobia, we have phobia of fear of at least two places. Okay, fear of at least two places. Okay, fear of at least two places, and the patient having a what? Avoidance behavior. So fear of two places and avoidance behavior. So fear of open space, fear of crowded place, fear of height, fear of closed space, any two places, and person having a avoidance behavior, not feeling like going to these places. It's a most common type of phobia is a agoraphobia. Okay, in any phobia, if they ask you the treatment of choice, it's a behavior therapy. So usually we use cognitive behavior therapy in an anxiety disorder, in panic disorder, in PTSD, in depression, in eating disorder, but here we use what? Okay, yeah, here we use the behavior therapy. Which behavior therapy is the most commonly used? Systemic desensitization. Systemic desensitization. Okay, most commonly used behavior therapy. Then we have the 26 is a from where escape is difficult. Basically we have places is given, so basically the answer will be B for Bombay. Answer will be B for Bombay. 26, more than one place. Neologism 27 is seen in, already we discussed, it's a schizophrenia. So it's a answer is B. Neologism is seen in schizophrenia. 28. A woman has mild depressive symptom after few days of delivery, which disappears within 2 weeks of the postpartum period. the most likely diagnosis is, already we discussed postpartum blues. So we discussed postpartum depression, postpartum blues, postpartum blues, and postpartum depression. Yesterday I mentioned that onset of postpartum blues is 3 to 5 days, is usually found in 3 to 75% female, and within 2 weeks the symptoms get resolved. Okay, so there is no medication is required in postpartum blues, only support to mother is sufficient. Postpartum depression, we have the development, the within, like we have 1 to up between 1 to 3 months after delivery, the female will have proper depressive episode in after delivery. We call it a postpartum depression, and we require the proper medication for the same. We require the medication for the same. Clear? Okay. One, we discussed acute and this thing. I'll just mention. We discussed the EMDR, the PTSD, acute stress disorder, and adjustment disorder. So what is adjustment disorder? I'll just explain you a little bit what is adjustment disorder. Adjustment disorder, we have basically, it's also that's why the previously we were describing it in a mood disorder. Okay, dark pen. Okay, I'll use dark pen. Okay, you want thick, little thick? Okay, I'll do that. Now it's better. Okay, so adjustment disorder. Is it okay, guys? Okay. So adjustment disorder, the first history, the examiner will start MCQ with the history of serious illness, either in close person, closed one, the loved one. Okay, either history of serious illness or the history of breakup. Okay, so history of migration. Yeah, so any the migration from one place to another place, that there is a breakup, there is a history of serious illness in the close person. Like examiner will start the MCQ, the person came to know that his mother is suffering from cancer, so the history of serious illness in a close person, mother. And then the examiner will say that after knowing that the person started having a low mood, sleep disturbance, okay, some depressive symptom, but these depressive symptoms are not severe enough for making a diagnosis of the depression. So the symptoms are there, but they are not very persistent and they are not very severe. And the last important thing about adjustment disorder, you have to remember that we are making this diagnosis within 3 months after knowing the history of serious illness in closed person. So adjustment disorder, how you will differentiate it from the depression, because many times the students get confused. Number one, examiner in adjustment disorder will start the MCQ from the history, either person migrated from the one place to another place, there is a issue of breakup, or the history of serious illness in the family or the closed person, and then there is a depressive symptom, but these depressive symptoms also not severe enough that that person can make a diagnosis of depression. The depressive symptom will be there, but severity won't be there. And then the last important thing, the person should develop these depressive symptom within 3 months after happening this either serious illness or breakup or something. So after this incident, suppose today you came to know that your mother is suffering from cancer, and after 6 months if you develop that depressive symptom, then it is not adjustment disorder, it is independent depression. So making a diagnosis of adjustment disorder, the development of symptoms should be within 3 months after this incident. Okay, so this is the adjustment disorder. Sometime even the classification suggests that even within 3 months examiner is giving the history of serious illness, also is mentioning the symptom within 3 months also. But if the symptom severity is given so high, still you should not make a diagnosis of adjustment disorder, and you have to make a diagnosis of the depression. So for making a diagnosis of adjustment disorder, I'm just last time repeating: number one, the any history of serious illness or the breakup or the migration issue, or the second, the development of depressive symptom, but severity should not be very high, and the development within 3 months after happening this after this incident. Okay, so before we are counting the adjustment disorder under mood disorder, but now we count under the trauma and stress related disorder. Correct? Okay, so question number 28, the answer is A. Number 28, answer is A. Question number 29. Not a fundamental symptom of schizophrenia. So autism, automatism, association, and ambivalence. So there was a person, Emil Kraepelin. Emil Kraepelin. Emil Kraepelin, he given the name, he did not give the name schizophrenia, he is given the name dementia precox. Dementia precox means dementia of early onset. Okay, early onset. And he also given the name MDP, manic depressive psychosis. Manic depressive dementia precox. Later on, we started calling what? Schizophrenia. And who has given the name schizophrenia? Eugen Bleuler. Bleuler has given the name schizophrenia and manic depressive psychosis. Now we call what? Bipolar disorder. Bipolar. So dementia precox, the name given by Emil Kraepelin, that also they ask in MCQ. Schizophrenia, the name given by Bleuler. Okay, Bleuler has given some symptoms. He told that these symptoms, if they are there, we can make a diagnosis of schizophrenia. And these all symptoms of Bleuler start from A, so that the one famous name came in limelight is 4A of Bleuler. 4A of Bleuler. In 4A of Bleuler, we have first A is autism, second A is ambivalence, the third A is affect disturbance, fourth A is association, so ambivalence, affect disturbance, association. Autism, the patient of schizophrenia has what? Autistic thinking, or the social withdrawn behavior. Socially withdrawn behavior. Ambivalence, the person is not able to make a decision whether to go for it or not to go for it. Confusion, it is ambivalence. And that the person having an emotional dysregulation, the emotional get disturbed, affect disturbance. And because of schizophrenia, severity of the symptom, that the person or the patient of schizophrenia is not able to make a the his or her, the sentences will not be in a consequence. Okay, so he's not able to put his thought process properly in a sequence. This is, association disturbance, or we call it a loosening of association. Nowadays we call it about formal thought disorder, which we discussed, in 2-3 MCQs before. So previously we were calling it a association disturbance or loosening of association. Now we call it a formal thought disorder. Okay, so these are the 4A of Bloiler. So we don't have, automatism, we have a autism. Okay, autistic thinking, fantasy thinking. But automatism is not a, the 4A of Bloiler. It's a automatism is a symptom of complex partial seizure. Correct. So the question number 29, answer will be B for Bombay. Okay. Question number 30, most commonly psychiatric illness seen in medico-surgical patient. That you should know. The most common the psychiatric illness we see in medico-surgical patient is delirium. Number 30, answer will be C. So we'll briefly discuss about the delirium. In delirium, basically the delirium is a neurocognitive disorder. In delirium, we have the cardinal feature of delirium, we have impairment of consciousness. So the impairment of consciousness is a cardinal feature of delirium. Because of impairment of consciousness, there will be disorientation to time, place and person. Okay, disorientation to time, place and person will have memory deficit. In memory deficit, we have a deficit of immediate memory and the remote memory remain intact. Okay, so the recent and immediate memory get deficit, remote memory get intact. Okay, we have transient delusion in delirium. What is transient delusion? Just remember, you got delirium again and again they are asking. Basically what happens in a delirium, the cardinal feature of the delirium is what? Impairment of consciousness, clouding of consciousness. Because of impairment of consciousness, suppose you are entering the patient is, you are entering, suddenly somebody entered in the room and patient says, sir, he or she want to kill me, they want to harm me, delusion of persecution, delusion. But second minute, because of fluctuation of consciousness, because of impairment of consciousness, patient will forget about it. So this is what the delusion comes, goes, aata hai, jata hai. That's why we call it a transient delusion. Okay, because of impairment of consciousness, there is a transient delusion. Okay, sundowning phenomena, that also they are asking again and again. Sundowning phenomenon. So what is sundowning phenomenon? As the sun downs, as the sun set, the patient condition get worsen. So in morning and afternoon patient remain better, in evening patient condition get worsen. We call it as sundowning phenomena seen in delirium patient. And patient have sleep wake cycle disturbance. Sleep wake cycle get disturbed. Sleep wake cycle disturbance. Okay, and we have one flocculation. What is flocculation? Flocculation is basically, they ask the flocculation, basically we have in a delirium patient. Flocculation kya hota hai yaar? Flocculation is like picking up, like patient is picking up threads, like patient lying on a bed and he will do on a blanket वगैरह पे ऐसे करेगा, that something is picking up. This is flocculation seen in delirium patient. So flocculation, that sleep wake cycle disturbance. Remember the sundowning phenomena, they can ask this, all the symptoms of delirium. Okay, we have an intracranial cause and we have an extracranial cause of delirium. We have a intracranial cause, this the subdural hemorrhage, we have a thrombosis, we have a epilepsy. Okay, in extracranial we have a cardiac failure, we have a respiratory failure, so hypoxia, we have a metabolic abnormality, sodium potassium imbalance, renal failure, the liver failure, so septicemia. There are multiple. Even drug related, we have delirium, drug induced delirium. Okay, they ask you the treatment of choice in delirium, the treat the etiology. Whatever the cause, you treat the cause, that is the treatment of choice. Okay, the haloperidol, we use haloperidol to decrease psychomotor activity. Psychomotor activity. Haloperidol or any antipsychotic, we don't use to treat the delirium, we just to calm down the patient, to decrease the psychomotor activity. But the treatment of delirium will be treat the cause. Whatever the cause is there, if there is an electrolyte imbalance, you target the electrolyte. There is a renal failure, cardiac failure, whatever the cause, you have to target the cause. That's the treatment of delirium. But sometimes we say the benzodiazepines. Please remember, benzodiazepine is a, it's a very, many times these people do this mistake, that patient entered in a casualty, there is an increased psychomotor activity, patient is running around, and the many time what happens, we have a lorazepam, diazepam in the injectable form in our casualty, and we give to these patients. And this is a blunder. Before giving any benzodiazepine in a emergency setup, you have to rule out delirium. Why? Because benzodiazepines are contraindicated in delirium. Benzodiazepines are contraindicated in delirium. They causes the cognitive deficit, and they can worsen the condition of delirium. Okay, so benzodiazepines are contraindicated, except only two delirium are there where we can use the benzodiazepines, and they are alcohol withdrawal delirium and benzodiazepines withdrawal delirium. Only these are the two conditions where the drug of choice is what? Long acting benzodiazepines. Otherwise, all other delirium conditions, benzodiazepines are contraindicated. Okay, yeah, contraindicated. So this is the about delirium. This is about the delirium. So most common psychiatric illness seen in a medical surgical patient, the answer will be delirium. Question number 31. Double depression is. So basically, what is double depression, guys? We have dysthymia. Previously we were calling it a dysthymia. Now we call it a persistent depressive disorder. Persistent depressive. So previously we were calling it a dysthymia. Now we call it a persistent depressive disorder. Persistent depressive disorder is what basically the person in dysthymia will have a subthreshold depressive symptom. Okay, subthreshold depressive symptom. Subthreshold means the depressive symptom are there, but they are not severe enough to make a diagnosis of depression. Subthreshold depressive symptom are there. The duration, we say in dysthymia, we say around 2 years. But please remember, this MCQ also they ask that if they give the child, in child it is 1 year. For making a diagnosis of dysthymia in children, we require the symptom duration only 1 year. In adult it is 2 years. Okay, so dysthymia, 2-3 things. The new in DSM-5 and ICD-11, the new diagnostic term we are using for dysthymia, persistent depressive disorder. The duration criteria 2 years. In children it is 1 year. Subthreshold depressive symptom. Treatment, we have SSRI and psychotherapy. Now what happens, suppose this 2 year duration, we have dysthymia, the subthreshold depressive symptom. In these 2 years, if we have at least one proper depressive episode, then we call it a double depression. So what is double depression? That double depression with dysthymia. Okay, so depression with dysthymia, we call it a double depression. Okay, double depression. So depressive episode on top of dysthymia, we call it a double depression. Double depression. So in this question number 31, the answer will be C. Okay, question number 32. Most common acute organic mental disorder. The most common organic mental disorder is what? Delirium. Delirium. Already we discussed. So the answer will be A. Delirium is the most common acute organic mental disorder. So dementia is a gradually progressive disorder. Delirium is a, okay. So sometime if they can ask that also, please remember that we have a delirium and we have a dementia. So delirium, we have, it's an acute onset. Dementia, we have a gradual onset. Okay, so we have a gradual onset is dementia. Acute onset, we have delirium. We have impairment of consciousness, and we have consciousness is intact in dementia. Okay, so that we have a impairment or clouding of consciousness in a delirium, but the consciousness is remain intact in a dementia patient. Okay, yeah, that you have to remember. The other like gradually progressive course we have in a dementia, so many, but these are the two important differentiating feature you should know. So question number 32, answer will be A for apple, delirium. Question number 33, non-diabetic non-hypertensive patient has some extra beat in the in pulse. The doctor informed it is benign, but patient is still going for the investigation from doctor to doctor. This is a type of the conversion disorder, hypochondriac disorder, somatoform pain, and depression. So answer will be hypochondriac disorder. So basically, what is the question number 33? What is hypochondriasis? Hypochondriasis, the new term, the new diagnostic entity, the new term of hypochondriasis, we call it a illness anxiety disorder. Illness anxiety disorder. In hypochondriasis, we have preoccupation regarding serious illness. Preoccupation regarding serious illness. Person is having a preoccupation regarding serious illness. Minor benign symptom or normal physiological function appear like a serious illness in the hypochondriasis. Person is having a little weight loss. Person will start thinking that I think I have a HIV. Person is having a little increased bowel sound. Person is start thinking that I have a what, the colon cancer. So the normal physiological function but the minor benign symptom appear like a serious illness. For making a diagnosis of hypochondriasis and ICD, we say that at least 6 months duration is required for making a diagnosis of hypochondriasis. The new name of hypochondriasis in DSM-5 and ICD-11 is what? Illness anxiety disorder. So the question number 33, answer will be B for Bombay. The conversion disorder, we have a dissociative disorder. Okay, so question number 33, answer will be B. Disulfiram is a type of, the question number 34, disulfiram is a type of, already yesterday we have discussed it. It's a aversion therapy. Okay, so question number 34, disulfiram, it's a aversion therapy. Okay, it's the aversion therapy. Person, we have metabolism of alcohol. We have alcohol, we convert into acetaldehyde. Acetaldehyde we convert into acetate. When we convert the alcohol into acetaldehyde, we use the enzyme alcohol dehydrogenase. And when we convert the acetaldehyde into acetoacetate, we use the enzyme aldehyde dehydrogenase. Okay, basically what happens, the disulfiram inhibits the enzyme aldehyde dehydrogenase. So when the patient takes the alcohol on top of disulfiram, alcohol will convert into acetaldehyde, but acetaldehyde will not convert into acetoacetate. And acetaldehyde will increase in our body and will give the acetaldehyde will increase, accumulate in our body and will give the reaction. We call it a disulfiram ethanol reaction. And in disulfiram ethanol reaction, patient will have skin rash, patient will have high BP, nausea, vomiting, okay, headache, severe. It's a severe condition. Sometimes patient even can die, so you have to be very careful. If you think that patient can take, better to avoid the disulfiram. Okay, today you had a reaction on a disulfiram, next time you will look at alcohol, even you will have aversion towards alcohol because already you had a severe reaction due to disulfiram. That's why we call it a aversion therapy. So disulfiram, the answer will be A. It's a aversion therapy, type of aversion therapy. Anti-craving therapy means the medication which will decrease the desire, decrease the craving of the alcohol, we call is a anti-craving agent. Yesterday I mentioned they are the acamprosate, baclofen, topiramate, naltrexone. Acamprosate is a anti-craving agent which is safe in liver disease. So from the first day, if you're an alcohol dependent patient, you want to start the medication, you want to start the anti-craving agent, you can start acamprosate. So question number 34, answer will be A for apple. Question number 35, indoor management of anorexia nervosa is done on a priority patient with, so we have eating disorder. So question number 35, we have eating disorder. In eating disorder we have anorexia nervosa. Anorexia nervosa, basically we have three criteria. One is we have the patient, the body, weight reduction, or the BMI is less than 18.5 according to current ICD-11. Okay, person is having a body image disturbance. Despite being very thin, person thinks that she is very bulky, and we have a 3 months history of amenorrhea. Okay, amenorrhea, and many other. The person avoid the fried food, the fat food, excessive gymming, running, cycling. Okay, very peculiar behavior, chopping the food, buying the time when the mom doesn't see, throw the food out of the window, or brushing under the carpet, in the cupboard. Okay, so these are many other behavior, but these are the important criteria in DSM-5 and ICD-11. This 3 months history of amenorrhea wala criteria has been removed in current classification. That also you can remember. We have some complications. Okay, we have some complication in anorexia nervosa. We have the anemia. Okay, we have the lanugo, the golden hair because of malnutrition. Okay, there is a osteopenia. Okay, osteopenia. All hormones will be decreased like LH, FSH, estrogen, except steroid. So any stressful condition, steroid is always increased. So all hormone including estrogen, FSH, LH, all hormone decreased except steroid. Okay, yeah. The treatment, we have CBT, cognitive behavior therapy. And we have a two type of anorexia nervosa. We have food restriction type, okay, and we have purging type. Food restriction type and purging type. Food restriction type is a most common type, and all, but we have a also purging type, and we have a bulimia nervosa. Bulimia. In bulimia nervosa, two important criteria. We have the the binge eating. Binge eating. The person eats more than the usual at a given period of time. Binge eating. And then the purging behavior. Purging behavior. Person does the self-induced vomiting. Okay. The enema, using the enema. This is a purging behavior. So bulimia nervosa is also, we have a purging type and we have a non-purging type. Purging type and non-purging type. But we also have anorexia nervosa, which is also have purging type, that you have to remember. Okay. Complication in a bulimia nervosa, we have a dental caries, animal erosion, hypertrophy of parotid and pancreas, metabolic, hypochloremic, kalemic, hypochloremic, alkalosis. Okay. If they ask you most common type of eating disorder, it's a binge eating disorder. Binge eating. In binge eating disorder, the binge eating will be there, but the purging behavior, the followed by the compensatory behavior, won't be there. So we call it a binge eating. The binge eating disorder is a disorder where we have increased weight. So in anorexia nervosa, we don't have increased weight, it's a decrease. In bulimia nervosa also decrease or normal, but in binge eating we have increased weight. So in this MCQ, we will have the weight for height less than 75% of normal. In that condition, we will do the indoor management in anorexia nervosa. So question number 35, answer will be C. And we have a question number 36. A 6-year-old child who doesn't interact with the other children of his age group and prefers playing alone in the same manner, likely to be, the child is basically the known case of what we have, autism. Autism, previously we were calling it a pervasive developmental disorder. Nowadays we call it a what? Autistic spectrum disorder. Autistic spectrum. In autistic spectrum disorder, in autistic spectrum disorder, we have autism, we have Asperger's syndrome, Rett syndrome, and Haller's syndrome. In autism, the child having a language and communication disturbance, and because of that, impairment in social interaction, and stereotype. So the language and communication disturbance, the impairment in a social interaction, and stereotype behavior. Same behavior again and again. Okay, by 3 years of age, we are making a diagnosis of autism. Okay, by 3 years of age, we are making a diagnosis of autism. Okay, we have MCHET, modified chart of autism in toddlers. MCHET, modified chart of autism in toddlers. It's a basically screening test. The screening test to screen the autistic children. Modified chart of autism in toddlers. Okay, so this is a autism. Basically, we have corpus callosum is a brain area which get affected in autism. In autism we have roughly 75% autistic children. autistic children 75% autistic children have comorbid mental retard. Okay, the autistic boys have 2 to 5 times more common mental retardation than autistic girls. And autistic boys have mild to moderate MR, but autistic girls have severe. Okay, so autistic boys have 2 to 5 times more common mental retardation than autistic girls. Autistic boys have mild to moderate MR, but autistic girls have what? Severe MR. Okay, so this is you have to remember. Overall we covered the all topics. Still you have some query, please let me know. Okay, delirium already we discussed. Jyoti, any query you have? You want in Hindi? Some students want in okay. Autism already we discussed. ADHD, if you'll go through the previous MCQs, I have discussed. Okay, I have discussed. So I have discussed there about ADHD. Autism in this MCQ we have discussed. Okay, so overall the all topics I have covered. I hope you enjoyed the psychiatry. You will see that most of the MCQs will come from this area only. So please go through minimum effort and you will have maximum output. Again I am repeating, the basic subjects and the minor subject is a backbone of your exam in FMG. Basically, if you are very good in a anatomy, physio, biochem, the patho, pharma, the basic micro, the basic subjects and the minor subjects. In the major subject, I am not saying they are not important, but in major subject, you have to put a lot of effort, and the sometime output is the nearby exam. So basic and minor subject do thoroughly. Major subject try to be do like we are having these sessions, go through these sessions. So with the minimum effort you will get. So faculties are putting their best effort. So in the major subjects you can go through the classes and they will give you the maximum, the crux summary of the subject, and that will be really fruitful. But if you will go through the major subjects thoroughly, if you want to study in this last period, it will be very difficult, because in FMG there 150 you have to get out of 300, and this 150, if you are good, having a good hold in a 10-11 subjects, you can get 150 easily. But you will try to cover the all 19 subjects, then you will have difficulty, because in 4.5 months you can't have a good hold on a 19 subjects. Okay, that's from my side. Still, if you have any queries, you want to message me, you can search, and you can this is my personal number. If you have any query, please message me. If any query, if I would help you, I will feel fortunate enough as a faculty that I could do something for you as a teacher. Okay, I hope you enjoyed and we covered all the topics in psychiatry. So thank you so much. Best of luck. Be in touch and bye bye. Take care.